1.
Great. Good morning. I'm Erica Schiavelli. I'm the Deputy Executive Director here at the GIC. I'm just going to give folks a moment to get fully logged on to the webinar here. So just give us a couple of minutes. Great. So it looks like we've hit capacity for the webinar itself for registration. Thank you to all of you who have registered and joined us today. If you're joining us from YouTube, welcome to that as well. We're excited to have you here today so we can talk to you a bit about what you can expect for the upcoming plan year. Next slide, please. Great, thank you. Okay, so this is our agenda for today. Sorry, give me a second here. We'll start off with a very brief overview of the GIC, our carriers, who we are, and what we do. Most of you are pretty familiar with that, so we won't spend a ton of time on those pieces. We'll walk through potential benefit design changes for the upcoming plan year in FY27. Then we'll get into enrolling in and updating your GIC benefits, and we'll go to question and answer at the end. So next slide, please. Great. So just a little bit about the question and answer portion for today. I wanted to get you all started on the right foot. You can submit questions at any time during the presentation today using the question and answer function in Zoom. It should be at the bottom of your screen. We'll be reviewing your questions, and we have staff on hand to respond to them in writing in real time in the Q&A tab. We do have a ton of participants today, so we may not be able to answer every single question, but we will certainly get to as many as we can. And we will also be taking some of those questions verbally at the end here. So please feel free to give us your questions in the Q&A function at any time during the presentation. I wanted to note for those of you who are watching through YouTube live stream, you won't have the ability to use the Q&A function, obviously, because you're on YouTube and not on the Zoom webinar. However, you can submit questions to us for us to answer, not during the webinar, but for us to answer for you by going to our contact page that you can access through our website, and you can see the links here. But again, if you go to our website, mass.gov/GIC, you'll be able to find our online contact form and submit your questions directly to a member of GIC staff. So we'll take everything that we hear today and do a few things with that information. We'll compile and publish on our website the FAQs. So we have an existing FAQ document that I think Leslie or Emily will put in the chat for folks. So we have an existing FAQ document that you can take a look at while your questions, while we're doing the presentation today. Just to note that questions are the only thing that we'll be addressing today. If you have comments or feedback to share, please don't use the Q&A function. Your comments and questions are only visible once they've been answered by a member of staff. Otherwise, they're private. And any comments or feedback or things that aren't actually a question are going to be just compiled for feedback to deliver to our commissioners. So please only questions in the Q&A function. If you have feedback that you'd like to give directly to commissioners, you can email gic.info@mass.gov. I am actually compiling that feedback from that inbox for commissioners to review after our sessions have completed today. So please go ahead, email gic.info@mass.gov if you have any feedback. I've already begun compiling some of that, and we look forward to reviewing your feedback there. Again, we have an FAQ page, so please feel free to check that out before you're asking questions, because chances are your information is located there. Great. So if we could go to the next slide, please. Actually, the next slide, please, Leslie. Great. So just given that we had a little bit of a late start today, I'm going to go through these slides relatively quickly and note that the presentation that you're seeing today will be available online probably early next week. So these slides you'll be able to review at some point next week once we get it up on the website. So I will not spend a ton of time here. So the GIC's mission is to provide our members with sustainable, effectively administered, high quality and affordable benefits, and to use our influence to drive improved healthcare or improved health for members and higher value healthcare delivery in the Commonwealth. So this mission is obviously core to what we do every day, and it's a real challenge to be able to balance high quality and affordable benefits. And we'll be talking a little bit about that later today. Next slide, please. Thank you. So here we have just our GIC goals. The first two goals we really just reviewed in our mission, which are to provide access to high quality, affordable benefit options and to limit the financial liability to the state and others. So the third goal is interesting because we have over 460,000 members. We also have the opportunity to influence the healthcare market for the whole state. We take that responsibility very seriously. Finally, we're focused on being as efficient and effective as we can so that we can serve you well and provide you the tools and guidance to manage your benefits. We actually have a smaller staff here than you might think, so it's important that we operate as efficiently as we can. Next slide, please. Great. So just wanted to give a quick review of what we offer for benefits at the GIC: health, dental and vision, life insurance, long-term disability, healthcare independent care, FSAs, and the Employee Assistance Program. Please note just at the top that all offerings are not available to all GIC members. For instance, the GIC's FSA accounts are only available to active state employees, but cities and towns frequently offer their own such programs to their employees. Also, the EAP, as indicated by its name, is provided only to active state and municipal employees. Next slide, please. So just some key facts about the GIC here. As I mentioned, we have over 460,000 members, including over 100,000 retirees. That makes us the largest purchaser of healthcare in the Commonwealth with a $2.8 billion appropriation from the state. And we're governed by a 17-member commission, and we partner with over 900 agencies in state, regional, and local government. Next slide, please. So I think this next slide is really important, but I don't want to get too much into the weeds here. We do want to explain how the GIC is structured. So the GIC is self-insured, and that means that the GIC, through the state budget, holds the insurance risk and not the insurance company that you're enrolled in. So when you receive healthcare services, your doctor will send a bill to the insurance company, and that insurance company in turn pays the doctor. The insurance companies then bill the GIC on a weekly basis, and we in turn reimburse the insurance company for those claims. An important implication to this, and really a feature of this, is that if over the course of a year, members use more healthcare services than we projected, the state will pay more. That's the state holding the risk. But you, the member, would not pay more. And if members use fewer health services than expected, the money that remains is reverted to the Commonwealth by statute. So this is important to note here because I wanted to use an illustrative example. at the end, close to the end of last year's fiscal year, some of you may have heard that the GIC requested and were given a $240 million supplemental budget at the end of last fiscal year. And this really highlights what you see on the slide here. When claims run over what we have projected, the Commonwealth is responsible for paying the difference that comes from that. And that $240 million sub that we had at the supplemental budget, that we had at the end of last year was to cover claims that were over what we projected. So this is the way the GIC is designed to work in our establishing statute. And I just wanted to make sure that that was clear for folks, that the Commonwealth holds the risk in these situations and not the member. Next slide, please. Thank you. So again, just getting back to questions here for some of you who may have joined late. If you're viewing us on YouTube, you will not be able to use the Q&A function, but you will be able to submit questions to us for answering at a later time. If you go to our our contact page, which you can access at mass.gov/GIC. Again, you can submit questions if you're in the webinar on Zoom. You can submit questions anytime using the Q&A function. Questions will be private until answered, at which time they will become visible to all attendees. Questions are the only things that will be addressed today. So if you have any comments or feedback to share beyond a question, please do not use the Q&A function, and instead you can use the contact form linked below or email us at gic.info@mass.gov. And I'm compiling your feedback and comments for commissioners, and we'll deliver that to commissioners ahead of our next meeting, which is on February 12th. And with that, I will transition over to Cameron McBean, who will talk to us about our current partners and plan offerings, as well as what's to come, as what we'll be offering for the upcoming year. Cameron?
Thank you, Erica. Good morning. Could we move to the next slide, please? And one more. Thank you. All right, we're going to begin with a review of our active employee or non-Medicare health plan options. Now, these are what plans are available to you are determined by where you live. If you live in certain parts of Massachusetts, the Cape or Islands, you may not have access to our limited network plans. And then we have a regional carrier, Health New England, out in the western part of the state. For other residents of Massachusetts, we've got 4 broad network plans to choose from that are also available throughout New England. The Mass General Brigham Complete HMO is only available to Massachusetts residents. But then if you live anywhere in New England, you can participate in either the WellPoint Total Choice or Plus plan, or the Harvard Pilgrim Explorer. If you live outside of New England, there is one plan available for non-Medicare participants, and that is the Harvard Pilgrim Access America. Next slide, please. And then for retirees who are on Medicare, we have 3 Medicare supplement plans that are available. One from WellPoint, one from Harvard Pilgrim, and one from Health New England. Then for residents of Massachusetts, you may also opt into our One Medicare Advantage option, the Tufts Medicare Preferred Plan. Next slide, please. Now we're going to talk about pharmacy benefits as well as some of the other ancillary products offered by the GIC. If you are in an active or non-Medicare health plan, your prescription benefits are administered by CVS Caremark. If you are a Medicare participant, your prescription benefits are administered by CVS SilverScript. For members who are eligible for the GIC's active dental and vision plans, that's basically non-union employees. Dental and vision is provided by Altus Dental and Altus Vision. That is also our retiree dental and vision provider. Paul will discuss the retiree benefits in greater detail later on in our presentation. Flexible spending accounts are currently administered by TASC, but we are in the final stages of wrapping up a procurement for a new administrator for those benefit plans. We do expect that to change, but it is subject to a vote, so we can't announce a final determination until after that vote takes place on February 12th. Next slide, please. Okay, and with that, I am going to hand things over to our Executive Director, Matthew Vino, and he will discuss what we've done in the areas of cost containment.
Thank you, Cameron. Welcome, everyone. Thank you for joining us. So I'm going to speak first about some of the challenges that we've been facing with GLP-1 drugs to treat obesity. So as many of you may well know, we implemented a program mid-year this past year regarding this class of drugs, and I suspect many of you have questions specifically about this, and in particular, why we have implemented this Vida Health program for GLP-1s to treat obesity. And so I want to speak to those and hopefully head off some of the questions that you may have by addressing them up front. So as you may know, there was a veto of the GIC's budget last summer in the amount of $27.5 million, which was paired with a request that the Commission consider eliminating this class of drugs to treat obesity mid-year on January 1st, so mid-plan year. The proposal would not have affected conditions such as diabetes, but was focused on obesity. There was a separate bill filed in the legislature that would have allowed us to make a mid-year change, but that did not pass the legislature. So as a result, we had a budget deficiency of $27.5 million, and we had to address that in some way to balance our budget. So what we chose to do was to implement Vida Health as the sole prescriber of these drugs to treat obesity. And I'll review how we chose Vida and some other details, but I first wanted to address some of the frustration and concern that some of you may have had over the last 3 weeks or so. So as folks know, I'm sure these GLP-1 drugs for weight loss are extremely expensive, and they have a large impact on the GIC's budget. They're a significant reason why our premiums went up last year and again this year. So when that happens to us, that happens to the Commonwealth's budget. And so we were faced last year, and we continue to be faced with either eliminating coverage for these drugs or implementing a program like Vida that would allow us to maintain coverage but manage the cost. We acknowledge that this change for many of you may not be welcome, particularly in light of the change that we had to our formulary that CVS made for that eliminated coverage for Zepbound and required people to move to Wegovy. But what I want folks to understand is that we're really faced with the decision of either eliminating coverage or trying to manage it better, and we chose the latter. So now, having discussed the why, I'll now start to talk about the how, just the process that we went through, and I'll do this briefly. So on the next slide, so we had evaluation goals. We wanted to make sure that we had a solution that we could implement quickly because we needed to produce savings in the middle of the year, and we wanted to make sure that the program was of high quality and that the member experience would be the best that we can make it, and that you all would receive a high level of service. So vetting, we went through, as you'll see on the right-hand side, we went through our normal due diligence, as we always would, to make sure that the vendor met our requirements. So on the next slide, you'll see we selected Vida Health for a variety of reasons. The strength and comprehensiveness of their program. It's driven by a team of clinical experts in weight management with a real depth of expertise. They have a variety of tools and resources for members, including scales and activity trackers and the like. And they really are implementing an evidence-based program that is importantly also able to support a culturally diverse population. So the impact you'll see on the right, as I've mentioned before, GLP-1s, for GLP-1s for weight loss, you can only get them if prescribed by a provider at Vida Health. This will save us about $30 million annually at the GIC. Members will maintain access to GLP-1s as long as it continues to be clinically appropriate and the member continues to engage with Vida in the variety of supports that they offer. So with the why and the how taken care of, I just want to speak to just a couple of common questions that we've been getting from members. So who is Vida? Well, Vida's a platform, it's a partner, a clinical partner that we work with, and it's a benefit available to all GIC members. So if you're currently prescribed a GLP-1 for obesity and you'd like to continue that prescription, you must enroll with Vida, as I said, as they're the sole prescriber for the drug. If you have diabetes and you're prescribed a GLP-1 or sleep apnea or other conditions, there's not a requirement that you do so. So another question that we've been getting, when do I need to enroll in Vida? Well, Vida was launched for our population just a few weeks ago on January 1st. We're currently inside of a 90-day grace period that is allowing our members to enroll and start to engage with the providers at Vida and to manage the transition of prescriptions in a smooth way. So if by March 31st you've not enrolled in Vida or finished all of the enrollment requirements, your existing prescription will be denied at the pharmacy. So I want to be clear about that. So we strongly encourage you, if you're on these drugs today, to enroll in Vida so that you can continue to have access to that treatment. Finally, how does Vida produce savings to the GIC? Well, there are a variety of these programs available that are what are called deprescribing models that over a prescribed time period, whether it's 12 or 18 months, provide an off-ramp for folks to get off the drugs. That is not what this is, but so as long as your clinical conditions are still, your clinical presentation still requires and is appropriate for GLP-1s, that will continue. But we want to be clear that we save money by having fewer people on the drugs because we don't have any capability the way the market and our laws are set up to actually negotiate a better price. And the reason these drugs are so expensive is the price. So, so just want to be clear about the savings and how they accrue to the GIC and therefore onto the state budget. So another question that we've received is about data privacy with regard to Vida. A number of good questions here. And for that, I'll hand it off briefly to our General Counsel, Andrew Stern.
Sorry, I'm getting technical. There we go. We heard a lot of people who are concerned with their provision of personal information to Vida, and Vida as a telehealth provider is completely HIPAA compliant once you have established your account, a login with their system. My legal team has met with Vida and their legal team to confirm that they are not only HIPAA compliant, but their website is High Trust certified, which is the HIPAA certification. It's the highest level. We have walked through the platform with them to confirm that the information that you are providing is protected. It's also protected under the contract. We have a business associate agreement with them, which is a HIPAA compliance document that confirms their responsibility to keep your information private. They will exchange information with your provider through a HIPAA compliant process if you give them authorization for. The only part of the experience that doesn't fall within HIPAA is before you start providing your personal information to them. So anybody can go to the public-facing website, and whatever privacy policies that are typical for a website would apply there. Once you have established the relationship and you establish a login with them, from that point forward, it's just like going to your doctor's office. Your records and information are protected.
Thank you, Andrew. So with that, now we'll turn to the next section of the presentation regarding the potential plan design changes that will be before our commission for vote on February 12th. If we move to the next slide, I want to start with a little context for the changes that we are proposing for the coming year. Bear with us a moment. We're switching up our interpreters.
We're ready.
Great, thank you. All right, if we go to the next slide. So as I'm sure you are well aware, healthcare costs continue to rise sharply for everyone. And that is also true, of course, for the GIC. So based on our analysis, if we make no changes to our GIC benefits this year, we are projecting a 10.9% average increase in our premiums for the coming fiscal year. So you'll see that here in the purple box in the middle. Again, this is an average across all of our plans. Some of our plans may have, at the end of the process, we'll have a smaller or a larger increase. So this is an average across all of our plans. And so when our costs and our premiums increase at this level, this translates into about a $170 million increase in the GIC's line item in the state budget. So in October, the Governor's Budget Office informed the Commission that the state budget cannot accommodate an increase of this size. And they requested that the GIC develop and consider a series of benefit changes to reduce that budget line item by $100 million. So those are the benefit changes through plan design that we present you today. And all right, move on to the next slide. All right, so we understand that, we really do understand that rising insurance premiums are hardship for you, for us, for the state budget, for everyone who has health insurance. So we take this challenge very seriously. But these affordability challenges are very real. They're increasing for us, increasing for everyone else. When healthcare costs go up, the cost of premiums that pay for them goes up. And as you have heard me say over the last several years, and this is not changing, this increase in costs is driven largely by two fundamental dynamics. One is that the prices that are charged by doctors and hospitals for the service that they provide are rising at a faster rate this year, even than last year. And this is a problem that the entire state has to grapple with, and state leaders across state government need to grapple with. Also, the cost of prescription drugs is increasing. The prices that go along with these drugs, GLP-1 drugs, a variety of other drugs, it's increasing faster this year even than last year, as the manufacturers of these drugs just command higher and higher prices, especially for new drugs. So to tackle these core drivers of rising costs, you may have heard that Governor Healy has launched a healthcare affordability working group that is charged with pulling together real solutions to these long-standing problems. As executive director of the GIC, I've been asked to participate in that group, and I can assure you that I will be advocating very hard for solutions that get at these underlying cost drivers and can put us in a better position to protect your benefits from future cuts. On the next slide, just a little more context here. As you know well, we all pay for healthcare services largely in two ways: through health insurance premiums that both your employer and you share. Depending on your employer, depending on your date of hire, that percentage will be different, but your employer picks up a significant share of the premium. The other portion of this is out-of-pocket expenses, deductibles, and co-payments, which you pay directly 100%, and those are referred to generally as cost sharing. So the richness of a health insurance plan is generally described by how much of the total cost is covered by the insurance premium. And since the GIC has worked very hard for many years to keep member cost sharing low and stable, our benefit levels are comparatively high. So you see that here on the slide, that almost 92% of the cost of services are picked up on the premium, which is again shared by you and your employer. And I think it's important to note that even with the plan design proposals that we'll be talking through here in a moment, this will not generally change. The vast majority of the cost of your benefits will still be on premium and still be shared with, by your employer, the state, or the municipal entity that you work with. So with that as context, we're going to move on, I believe, now to the next section where we're going to walk through each of the proposed plan design decisions that are currently before the Commission. So this is the first change being considered, but let me orient you first to this slide, since each of the slides that follows has the same format. So here we lay out the first plan change. Below the blue bar in the left-hand column, you'll see a description of the proposed change. And as you're reading left to right, you'll see that we include a number of other columns that describe the impact of that change. First, we show where it's applicable, how this change would leave GIC plans compared to other public sector plans like the GIC. So we want to make sure that we're viewing it in the lens of what other plans that are similar to ours looks like. You'll then see in the next column, we're showing the number of GIC members that may be impacted by this proposed change. Then there's two more columns that show the savings, both to the state budget and to the and to our premium increase for the next year. So that percentage is how much as a percentage of our premium we will save. And then finally, you'll see on the right in the purple columns, we're going to show some colored bubbles to illustrate generally how each of these proposed changes align or maybe do not align with our strategic priorities of member affordability, behavioral health access, and health equity, understanding that these are all interrelated and these sorts of decisions are about trade-offs. So this proposal that's laid out here relates to the premium contribution percentage that applies to the spouse of a state employee who chooses to retain insurance coverage after the employee has passed away. So today, those members pay across the board a 10% of the premium, even if the deceased spouse had a higher percentage. So whether that's 10 or 15 or 20 or 25%. So the proposal here is to just make sure that the percentage premium that the surviving spouse pays is aligned with the percentage that was in place for that deceased employee. And so as you can see, this change would impact a little over 8,000 members. It would reduce our budget spend by about $3 million. And obviously, as purely a cost shift, would work counter to member affordability. So we note that in the red bubble. For this one, so I will highlight for each of these where they apply to our active plans and our Medicare plans. So this would apply to those enrolled in both active plans and Medicare plans. So on this slide, we lay out a series of changes that are pretty small in terms of our premium rate reduction, but are necessary nonetheless to meet our budget savings target that's been given to us from the administration. So, for example, the first row here shows a proposal to increase the urgent care copay from $20 to $30. As you'll see in the column just to the right, this is very much in line with the copay that exists in plans that we compare ourselves to, would impact about 60,000 members and produce about $400,000 in savings. Similarly, here in the third row, we're doing the same for the emergency room copay, proposing to increase it from $100 to $150, again, aligned very much with the plan design in comparative plans. In the second row, you'll see that this is grayed out and struck through. This was a proposal that we had presented to our commission that we have removed from the list for consideration. During COVID, we instituted through our employee assistance program called Mass for You, 3 free mental health visits delivered by telehealth. And we wanted to be able to continue to do that since just in line with our desire to do what we can to maintain and improve access to behavioral health services. Lastly, on this slide, the final proposal is to eliminate hearing aid coverage that is above the state mandatory minimum. So this would reduce coverage for those who are under the age of 21 from every 24 months to every 36 months. So the benefit will remain but be changed in that way. And we are proposing removing coverage for those who are age 22 and above. This would apply to both our active plans and to our Medicare plans. So here, rows 1 and 2 are related. Sorry, if we can move to the next slide. So here, rows 1 and 2 are related. So, and this is because we've modified a proposal that we had earlier presented to our commission, and we wanted to be transparent about how we had done that. So this proposal is to increase the coinsurance percentage that applies for out-of-network services in our plans that offer coverage for out-of-network services. That today is a 20% coinsurance. The proposal is to increase that to 40%. Again, this is in line with other plans that we compare ourselves to. What we have decided here, the modification, which is, you'll see the initial proposal that's grayed and struck through. The modification is, again, we wanted, in service to our priority of behavioral health services, we wanted to make sure that this change did not apply to those services. And that's because we acknowledge there is a shortage of behavioral health therapists. Many of them do not contract with health plans. So we were concerned that including behavioral health in this would lead to a substantial barrier to access for these services. So what you'll see is the amended proposal in the top row. The last row here proposes a change to the way our health insurance plans pay providers who are out of network. So this is not a change to the plan or copays or deductibles. This would happen more behind the scenes, how our carriers pay those providers. So we want to make sure that the incentive is really strong for providers to be in network with our plans. And we also want to be able to produce some savings here. So we are proposing paying these providers essentially what they also receive from the federal government for Medicare services. So a fair and reasonable rate, but with the incentive that that they join the health plans networks. So we're closing in here on the end. On this slide, we propose increases in copays for office visits to primary care physicians and specialists. As you all are likely aware, we have tiered copays for these providers. We want to have lower copays, so a greater incentive for our members to choose lower cost providers, which keeps our overall costs down. So the changes that we make here is a little more complex. So we change the copay for each tier. So for primary care visit copays, tier 1 today is $10, a modest increase to $15, which is still below the benchmark comparator with other plans. Similarly, we increased the tier 2 copay by $10 and the tier 3 copay by $15. The For specialists, the logic is very much the same. We're proposing to increase the specialist copay by $5, which would be aligned with the benchmark. Tier 2 would increase by $10 and Tier 3 by $15. So finally on this slide, the last two rows again here are related. So we are proposing an increase to the medical deductible for our active employee plans, and we considered two different levels of increase. The grayed out option is the one that we are not proceeding with, and so the proposal here is to increase the deductible in our broad network plans for an individual plan from $500 to $750, and for family plans from $1,000 to $1,500. For our narrow network plans, which tend to be lower premium and therefore have lower deductibles, we would be changing the individual tier from $400 to $650, and for the family plans from $800 to $1,300. And you see the information about impact on members and savings that this produces to the GIC on our budget end. So this, I believe, is the last slide that captures proposed plan design changes, and these are to the pharmacy benefit. First, we propose the introduction of a new program called Prudent RX. This would be offered through our vendor CVS, who manages the pharmacy benefit. This one's a little complicated, but I think from the member perspective, it's fairly simple. The program would lower copays for prescription drugs for members to $0 and save the GIC on our budget side almost $14 million. So this is accomplished by leveraging coupons that are provided by the manufacturers of drugs. These are co-payment coupons, and they apply to many expensive drugs and are used by many of our members today. So here, the members must enroll in the program if the drug that you are taking is one of the drugs included in the program, and your copayment will be $0. But if you fail to enroll in the Prudent RX program, your copayment may increase substantially. So there's nothing that anyone needs to do proactively about Prudent RX. If the commission decides to proceed with this program, CVS will reach out to you proactively to let you know if the drug you are on is part of the Prudent RX program. They're there to help you. They will help you enroll in the coupon that will reduce your copay and bring some additional savings to the GIC. But again, we've gotten a lot of questions on this one. We don't yet know which drugs may be subject to the program. And so we want to just sort of ease your mind that when and if this program comes into place, you will be contacted by CVS and you will know the steps that you need to take, and they will help you do that. So the second and final proposal here, it's a very difficult one for us, is the proposal to eliminate coverage for GLP-1s for weight loss. As I mentioned earlier in the presentation, we've been struggling to manage the cost, but really trying hard to maintain coverage. We implemented the Vida Health program that I described, but in order to meet the budget savings target that has been given to us by the governor's budget office, we had to have this on the list of potential changes for the commission to consider. I'm going to come back to GLP-1s again in a moment, but that concludes the proposed plan design changes. Just to be clear to those who are on Medicare plans, the two changes that apply to you is the surviving spouse premium contribution change and the hearing aid benefit change. The rest of the plan design changes, also for the active plans, all of these will apply. So just wanted to be clear about that.
It doesn't look like
So that concludes the review of plan design changes. You may be wondering how this all sort of, if all of these changes are made, how that affects our premium and how it affects our state budget. So as I said, if we approve all of these through the commission, that would save us approximately $100 million. If we make none of the changes, our premiums will increase by 10.9%, which I've noted before here in the red box in the upper right. If we make these changes, we reduce that number by 4.9 percentage points. And so in the lower left, you'll see the resulting approximately 6% average premium increase as we head into the new year. It is important to note here again what I suggested, what I mentioned earlier, which is that this is an average number. So if all these plan design changes are enacted, our average increase would be 6%, but each individual plan will be different. You'll have some that are increasing by more than 6%, some likely less than 6%. All right, so let me round this out with a couple more observations before we hand it over to one of my colleagues. So as I noted earlier, the GIC is working very hard to keep your co-payments and deductibles low and stable. And in fact, aside from some very minor adjustments we made back in fiscal year 24, we have not increased member cost sharing in 8 years, co-pays and deductibles. This is very unusual. Employers in the private sector that offer insurance to their employees routinely increase member cost sharing. We see this across Massachusetts and across the country. So we have done everything that we can to resist having to make these changes, but with the state's budget challenges, this is apparently no longer feasible. And as a result, we have had to propose to our commission some modest changes to cost sharing, a modest change to the contribution rate for surviving spouses. We are proposing some reforms to how we pay out of network providers, implementing this new pharmacy program. Some of these changes are increased costs directly to you. We acknowledge that. Others of these produce savings to us without an increase in spending for you. For GLP-1 drugs to treat obesity, this one, as I've said, is sort of a unique challenge for us. So I just wanted to say a couple more words on that before we move along. So as I've said, the very high price for these drugs is a very significant driver of our rising costs this year. Many health insurance companies and many, but not all, employers are dropping coverage for these drugs as a result. For our commission, this would be a difficult choice because we also acknowledge that these drugs are highly effective and treat a chronic condition that has high prevalence among our membership. And we have, this continues to be a very dynamic environment around these drugs. There's many unknowns. There was just recently approved an oral version of the drug. We launched Vida Health to try to manage this. For those who are on this drug, you know that we made the formulary change last year. So it's just a very dynamic space, and we're trying to navigate that as best we can and try to preserve this coverage if possible. But, but if the commission is going to reach the budget target that we've been given, we have to follow suit with other employers and terminate this coverage. That said, this is a decision made by our 17-member board. Legislature doesn't make that decision. Governor doesn't make that decision. And I don't make that decision. Only our commission can make this decision. So they will be voting on that and all these changes on the 12th. So that's the substance of our plan design changes. I just want to close here with some brief words about the process that we go through to prepare rates and plan design. So we start the process in December by bringing our early projections for spending for the coming fiscal year, assuming we make no changes to our plans. Then we come back in January and propose plan design changes. This year was a little different because we knew of the need to produce savings to the state budget, so we started those discussions with our commission actually back in November. But that's what led us to our January meeting, where we refined those proposals and provided additional data to the commission. Now we come, as we always do every year, before the commission votes, we want to inform our members about the proposed changes. As I've mentioned, February 12th, our commission will meet and vote on these plan design changes. On the 26th of February, that's the last step in our process with our commission, where they will vote on the resulting premiums for each of our specific plans. Then we head into annual enrollment with which this year starts on April 1st and ends on May 1st for the coverage that will include any changes starting on July 1st of this year. So a brief overview of our process and timeline. And I think with that, I hand it back to Erica or to Paul Murphy, who will go through the final section of the presentation.
Great. Thank you, Matt. Wonderful. So just before we turn over to Paul, wanted to review again our process for submitting questions. So you all have been doing a great job giving us questions in the Q&A function. So keep them coming, and we're going to do our best to answer them all today. Again, for those of you who are watching through the GIC's YouTube live stream, you won't be able to use or view the Q&A function. However, once these sessions, this is our third session, our last and third, once we finish this up today, staff will be reviewing all of the question and answer transcripts, and we'll be updating our FAQs on our website with the questions and answers that you have asked today. A transcript will not be available of the Q&As because we do have a lot of folks who have put personal information in the Q&A, and so we cannot distribute that direct transcript, but we will be kind of translating it into an FAQ document. So that's actually a good reminder for folks. If you are still asking questions, please don't put your personal information in the Q&A. If you have a question that is specific to your personal situation, please go ahead and get us on at our online contact form. And you can access that at mass.gov/GIC to access our online contact form. Again, we're only addressing questions today that have wide applicability. If you have personal questions, please reach us at our contact form. I think that we can move along to, oh, actually, one more thing I wanted to say. We have been getting a lot of feedback in the Q&A form, in the Q&A function. I want you to know we see it, but we're not addressing it today in the Q&A section. Some of you are also really good at providing feedback that sounds like questions. So I welcome that, but please send it to gic.info@mass.gov. I am behind the scenes pulling that information, that feedback out and compiling it for commissioners. It's not an inbox that we use the rest of the year, so you will get an auto reply that I'm working on updating. But please know that I'm there behind the scenes. I am looking at that email inbox and I am compiling that information myself. So again, if you have feedback for commissioners, gic.info@mass.gov. Great, and now I will turn it over to Paul.
Thank you, Erica. If we can go to the next slide after this. So on the next couple of slides, we like to share some important dates and some key reminders for the upcoming annual enrollment. So this year, annual enrollment will take place April 1st through May 1st. So just as a reminder, during this time, employees can change health plans, change their coverage individual to family, family to individual, enroll for the first time, and they can also sign up for the GIC's buyout program. This year's benefit decision guides are going to be available immediately prior to the start of annual enrollment. The guides will have all important information, plan comparisons, as well as the new rates for July 1st. The guides will be posted directly on our website, as well as the GIC member portal. I also would like to remind we have 11 new municipalities joining the GIC for July 1st, and those employees and retirees in those municipalities joining. This is also the time frame to sign up for your benefits for July 1st. If you could go to the next slide. So this slide is just a reminder that the GIC launched a portal a few years back where members can go in and view their benefits. Currently, we have about 136,000 members utilizing our member benefits portal. The portal will allow you to see your benefits 24/7 throughout the year. You can update your personal information, and you can also make online benefit changes for annual enrollment or a qualifying event throughout the year. You can update dependent information in this portal, and we encourage members that if you have not already registered for the portal, to register for the portal before the start of annual enrollment, where you can make important changes online directly without having to send in paper applications to the GIC. For more information on the portal, you can visit our website, mass.gov/GIC. On the homepage, you will see a tile, and it's called the My GIC link, and that's where you can find out information on how to register for the upcoming annual enrollment. I would encourage people that if you want to register for portal, please try to do it before the start of annual enrollment. Our phones get very busy during annual enrollment, so it would be helpful if you have any difficulties, you can reach out to the GIC using the online contact form, and we encourage people to do that before the start of annual enrollment. If you could go to the next slide. On this slide here, we're giving important information regarding the health plans, their website, and telephone number. At the top of the slide, you'll see when a member should be contacting the GIC. Many times members reach out to the GIC and ask us questions on providers, tiering, what programs are available, and understanding their coverage. We encourage people to reach out to the health plan directly using these websites. phone number. We also have the information posted on our website for members that want to find out information about the other plans that GIC offers, such as long-term disability, the dental vision coverage, and life insurance. So what I would encourage you, if you want to find out information, you can go to our website. You can see all the plans that we offer. And within our website, there are hyperlinks where you can click on the hyperlink and it will take you directly to that vendor's GIC specific page. And I think that's the last of it, Erica.
Yeah, I believe so, and we'll turn over to questions. Okay. As you can probably hear me click-clacking back here, I'm answering one last question, and then I'll turn over to verbal questions here. So one question we got that I'll pose to our general counsel, Andrew, is about the Vida providers and whether they're licensed in the states where they're prescribing. So Andrew, if you could speak to that, that would be wonderful.
Be happy to. I'm not hiding in the shadows here, but it may look that way. All Vida prescribers are licensed in the states where they are writing prescriptions. They have providers across almost all states, and Vida itself has to be licensed within the states where it does business. If they're prescribing in Massachusetts, they're holding a Mass license. But since our members are national, they may be dealing with prescribers that are not Mass licensed there, but for the state wherever they are.
Thank you, Andrew. Okay, we had a couple of questions about the hearing aid benefit specifically. Andrew, I think I asked you to speak to this yesterday, but about what the change is and why we're posing that as a potential change. Andrew, could you speak to that a little bit in terms of what the state mandate is and what this change would do? Andrew, did we lose you?
You did. Can you hear me now?
Yes, yes.
I was totally frozen.
Oh, okay. We can hear you now. Thank you.
All right. I think I've lost my camera in the process, but as long as you can hear me.
Great.
A number of years ago, the legislature passed a statute mandating hearing aid coverage for people up to the age of 21. It is in our statute. It is also in the managed care business that DOI regulates. At the time, we wanted a more enhanced benefit. And so our hearing aid coverage has been better than what the legislature mandated. Unfortunately, it's one place where we could reduce coverage to just comply with what we were told to do rather than what we wanted to do. And that's why it's on the list. I understand that people over 21 need hearing aids. Some of my staff wear hearing aids. It is not something we are doing without due consideration or lightly. I would love us to be able to continue the benefit as it is. It's just whether or not we can afford to do so. Also, for those on Medicare, Medicare, when it's primary, has its own hearing aid coverage that is separate from our benefit. It's covered through Medicare itself and will not be affected by this.
Thank you, Andrew. Okay. Let's see here. I think Andrew or Cameron, if you could speak a little bit to Prudent RX. This is the drug coupon program for folks that are wondering. If you could speak to that, I know we don't have a list of drugs yet, but we have a lot of folks asking. So if you could just speak a little bit more to the Prudent RX program, Andrew, please. Thank you.
Sure. See if I can get my camera to come back up. No, it's not going to do it. The Prudent RX program is known as a coupon maximizer. All the PBMs have these programs. They only apply to a subset of specialty medication that have manufacturer coupons available to them that would cover a large chunk of the cost of the drug. What the program does is it asks our members who are on these specific medications, and there will be outreach to those members once, if we do decide to move forward with the program, to sign up. The benefit for the member is that they will no longer have any cost for the medication. And the benefit for the state is it will get the full value of whatever the manufacturer coupon has. The downside to it is that if a member does not sign up, these drugs get moved off the formulary to be part of this program, and they could face up to a 30% coinsurance for the drug. This is one of the reasons we've not enrolled in the program to date, but there will be extensive outreach to make sure that everybody who is on an applicable drug has an opportunity to sign up and will be encouraged to sign up so they don't face any out-of-pocket expenses. If you have more questions, let me know.
Great. Thank you, Andrew. We've gotten a couple questions here about these potential plan design changes and when they're going to be voted on or decided. And so just to reiterate for folks, these potential plan design changes are up for a vote on February 12th. That's our next commission meeting. Commissioners will vote on these potential plan design changes at that time. Again, before that vote, we welcome your feedback for commissioners. You can provide that at gic.info@mass.gov. And these slides and the recordings will all be available on the GIC's website, mass.gov/GIC, early next week, if not tomorrow. So just wanting to address a few of the questions that we see in the Q&A regarding that. We did have a question, just a moment, please, about our dental and vision and how that eligibility varies. So if you are in a union, your vision and dental benefit likely comes through your union. It will not come through the GIC. So please just note that. And then we also have, for municipalities, there are some different eligibility requirements depending on the municipality you're coming from. So your dental and vision may be different, and your access to certain benefits that GIC offers may be different. So just a note for some folks who are union or in municipalities, just to double check that. And if you have questions, again, use our contact form at GIC, mass.gov/GIC. Okay. Let's see here. So we've had a couple of questions come in about more questions about Vida. And yes, this is a broad info session, but we're getting a lot of questions, and we want to be responsive to our members that are asking about GLP-1 specifically. Just to be clear, if you are on a GLP-1 for diabetes, for a diabetes diagnosis, you do not have to go through Vida. At this point in time, everything else will have to go through Vida. That is my understanding. Andrew, please correct me if I've said that incorrectly, but that is my understanding that at this moment, the indication that is not having to go through Vida is diabetes, not pre-diabetes, not sleep apnea. All the rest will have to go through Vida. So I just want to clarify that for a lot of the questions that were being asked. And Andrew, just want to get the nod from you that I've said that correctly. And haven't misstated anything, but that is my understanding.
That's correct. I will say that there should be um, a page that will be going up on the Vida with language that makes it clear to members if they have gone to the Vida site and is trying to register that and get excluded, that it was because they had diabetes or some other condition. I'm not sure that that's functioning yet because we have to give them the language. But you're correct on how it applies.
Thanks, Andrew. Just a couple other things around GLP-1s. So one, we've had a lot of folks ask about the pill version of Wegovy that has come out, whether or not it is covered, and if that goes through Vida. It also does go through Vida. It is presently on the formulary, and what we have seen is that some folks have asked about the cost. What we have seen is that the cost of the pill is pretty comparable to the injectable itself. So there's not really a cost savings measure to be found there. So just wanted to address that as well. We've gotten a couple of questions about, let's see here. Sorry, the questions keep jumping around as I'm trying to find questions to ask here. So just bear with me for a moment, please. So we've gotten a couple of questions about, in terms of the hearing aid coverage, about whether this would include cochlear implants as well. That's not something I have the answer to off the top of my head, and I'm not sure if Andrew or Cameron, you have that answer. And if not, we can certainly get back to you with that question or with that answer. But Cameron, Andrew, anything to offer?
I do not know whether or not cochlear implants fall under the hearing aid benefit as it's written. I do have some outreach to our medical carriers, so we can probably include that in the summary that gets posted.
Great, thank you so much. Great. Okay, let's see here. So I think what I'd like to do, let's see. I think what I'd like to do is to turn to Paul quickly, just to give us a quick overview on Medicare and retirement, because we do have a few questions about that in the question and answer function. And I think that, Paul, you usually do an excellent job of addressing those questions. Again, if you put personal information or you have personal questions, please reach out to us using our contact form at mass.gov/GIC. Paul, if you wouldn't mind just giving us a quick overview.
Sure, I can give you, again, a high-level overview. We can't address every combination of coverage for members and spouses and dependents, but I can at least give you some guidance. If you are planning on retiring, in order to continue your GIC benefits, you must submit an application for retirement to GIC to continue your benefits. And we ask that that application come in within 60 days of your planned retirement date. You can also use our member portal and click on qualifying events and use the retirement tile to walk you through the application for retirement. We get a lot of questions from members about Medicare. When should I join Medicare? What do I do? I'm covering a spouse. Try to make this simple. If you are retired and you are under age 65, you and or your spouse, you can continue your GIC benefits at retirement until such time you reach age 65. 3 months before your 65th birthday or your spouse's 65th birthday, we will send a letter to the member and the spouse asking about Medicare eligibility. State law requires all family members eligible for Medicare Part A and Part B to enroll in Medicare with Social Security directly and elect a Medicare plan with GIC. So our letter will give you instructions. It will go out 3 months before the 65th birthday, and we will list all of the Medicare plans available to the member at that time, as well as the spouse. If you are age 65 or older at retirement, you and your spouse will receive the same letter with instructions about the Medicare eligibility and you enrolling in Medicare A and B and electing a Medicare plan with GIC. That letter will be sent as soon as GIC is notified of your retirement. If there's a combination of a family member where you have somebody who is over age 65 and under age 65, GIC still requires the over 65 participant to enroll in a Medicare plan, and a spouse or dependent under the age of 65 can remain in the GIC non-Medicare plan that you had prior to turning 65. So we offer many different combinations of coverage for Medicare. If you are working and you're going to continue working after age 65, the GIC encourages you to enroll in Medicare Part A and defer the Medicare Part B until such time you, the member, retire. Once you retire, state law will then require you to go and enroll in Medicare Part B. So you can defer the Part B if you're going to continue working after age 65. You can enroll in Part A. Part A is free, hospital insurance with Social Security. Medicare Part B is $202 a month, and you enroll directly with Social Security. You do not need to enroll in Medicare Part D. D is in dog, pharmacy benefit. GIC health plans all cover pharmacy, and you do not need to enroll in the Medicare Part D at retirement. So again, there's many different options available. And one area where we do tend to get a lot of questions is on the dental vision. As Erica said, the dental vision plan that GIC offers is available to a small select number of employees not covered by collective bargaining. If you are covered by collective bargaining and you have benefits through your union, you have the option to continue those benefits when you retire through the benefit of COBRA, in which you must pay directly the 100% premium. So whether you're with GIC's plan or with your union plan, you have that option to continue COBRA for 18 months following retirement. You also have an additional option. If you are a state retiree, you have the option to enroll in GIC's retiree dental plan. So it's a plan that is available to all state retirees and some employee retirees from municipalities. If you want to find the list of municipalities that offer our retiree dental, you can go on our website. But for state retirees, everyone is eligible for the retiree dental plan. You can do it at retirement, enroll in the plan. You have 60 days from your retirement date to enroll in the plan, or you can defer that till after your COBRA expires, or you can come in during any annual enrollment period. One word of caution, if you enroll in the GIC retiree dental plan and you want to cancel that plan, if you cancel the GIC retiree dental plan, it is a lifetime lockout. You cannot re-enroll in that plan again. So there's a little bit of homework regarding your options. You have options through COBRA, which is a continuation of the benefit you have, dental and vision, with your union or with the GIC plan, or you can select retiree dental at retirement, defer it till after COBRA, or enroll at any annual enrollment period. So again, that's very high level, but I'm just providing what I can in general. You can reach out to GIC using our online contact form, or even our member portal will walk you through all of the options when you retire if you want to enroll in retiree dental or even our COBRA dental plan.
Great. Thank you so much, Paul. Again, so we just got a question. It would, be helpful to have this info somewhere. If we do, if you, Emily, could drop in the chat, or Leslie, again, the Turning 65 video, I think that would be really helpful. So we're running up on time here. And I would just like to remind everyone that while we still have a lot of your questions that are open in the Q&A, that we are going to address them where appropriate in our FAQ document that you can find at mass.gov/GIC. And I think for folks who are on the webinar itself, you should be able to get that link in the chat. So again, the vote on the potential design changes that we've shown you today in order to meet the target that we've been given, those will be up for a vote on February 12th at our public meeting. It's on Zoom, so it is available for folks to watch via our YouTube live stream. So you can take a look at that meeting as it's happening or thereafter to find out how the vote went, essentially. In the meantime, if you would like to provide feedback to our commissioners ahead of that vote, you can do so at gic.info@mass.gov. Again, I'm there behind the scenes, not filtering, but pulling these emails into a folder, essentially, to compile them and share it with commissioners ahead of that vote. So if you have feedback you'd like our commissioners to hear, please go ahead and email it to gic.info@mass.gov. And with that, I'm going to suggest that we close out the session. Matt, is there anything you'd like to say as we're wrapping up here?
Thanks, Erica. Just that I see that we've answered 268 questions live. And so we've done our very best to do that. I would encourage folks, as Erica said, to reach out to us directly, either by that email address or through our online contact forms. Look, we recognize that these are not, for the most part, welcome changes to the GIC's plans. We share the concern. As I mentioned in one of the comments, these decisions or these proposals are driven entirely by a budget-related need, given the Commonwealth's financial picture. So we are doing our best to meet those obligations, but we always have very much top of mind the interests and needs of our members. So thank you for being part of the process, and stay tuned. We really appreciate the engagement.
Thank you all.